Okay, we will go ahead and get started. My name is Tom Campbell. I'm a professor of medicine in the Division of Infectious Diseases. And we have a very special speaker here today, Roger Glass, who is coming to us to speak in a program sponsored by the Center for Global Health, jointly with the Department of Medicine. It's really a great privilege to have Roger here today to talk to us. Roger has had a very distinguished career, starting with magna cum laude graduation from Harvard University, or Harvard College, I should say, followed by a Fulbright scholarship, which I would guess is probably what got Roger started on his career in global health. He's also obtained a MPH from Harvard School of Public Health, PhD from Göteborg University, and his MD from Harvard Medical School. Roger has had an incredibly productive research career. For 20 years, he served as the director for the Division of Viral Gastroenteritis Diseases at the CDC. Roger has over 500 publications, primary research publications, has had numerous scientific awards for his scientific achievements, particularly in the area of rotavirus and norovirus epidemiology, work that was very important for the development of the rotavirus vaccine. But I would say that perhaps his biggest contributions to global health came when he was appointed the director of the Fogarty International Center. And for those of you who aren't familiar with Fogarty, it has an annual budget of about $69 million and funds over 400 projects, research projects, worldwide research and training projects that involve U.S. universities partnered with institutions in other parts of the world. So there's really no one I can think of that's more qualified to talk to us today about global health in the 21st century. So please join me in welcoming Roger Glass.
Thanks, Tom, for that nice introduction. I wish my mother was here. I'm really delighted to be here and speak to you about global health as we see it from Fogarty, from NIH, and give you a little background about how I got interested in global health, and then tell you a little bit about the vision that we've developed over the last few years at Fogarty at NIH. And then some ways at the end about how you can be engaged more and how you already are engaged here in Colorado. And I must say I met Tom in through the MEPI grants, which we have been working on for several years in Africa, and it's been delightful through that connection to see all the things that are going on here in Colorado. So let me just start with a little background because my interest has been in diarrheal diseases. And I really got interested when I was an undergraduate in the History of Science department at Harvard. And I saw this graph about the Broad Street Pump. All of you heard about John Snow and the Broad Street Pump? Well, I read this and I said, God, this is really a great disease, and it's all related to the water pump. And if you really wanted to control cholera, you just had to take the handle off the pump. Isn't that what it's all about? So with my wife, who's a pediatrician, we went off to Bangladesh in 1980, and we went to find the water pumps where we could take the handles off the water. Isn't this what you do to control a disease? Well, it turns out that there was a $100 million project to put water pumps throughout the rural area of Bangladesh where I was working, and these made absolutely no difference in the transmission of waterborne diseases. Can you imagine spending $100 million on a project and having it fail? And so this got me to thinking, well, what went wrong? How are we different from, let's see, where are we going here? There we go. It's going backwards here. I got the wrong way. where are we going wrong? And one of the things we found 25 years later was that these tube well water that we were putting in and that I drank for 4 years when I was in Bangladesh was loaded with arsenic. It was microbiologically pure, but was loaded with arsenic such that people in that community got chronic arsenic poisoning, an environmental hazard. And if you want to study the toxicity of arsenic today in the world, Bangladesh is the place to go. So the intervention that we thought was really helping people really brought about a disease and a problem that we never anticipated. Another thing that we learned was that in the difficulty in treating cholera, which is the most severe diarrheal disease, you lose a liter of water an hour and you can become dehydrated in a day, that while you could rehydrate people with intravenous fluids, people in the rural areas where you didn't have IV fluids needed something else. And oral therapy became the treatment of choice, developed in Bangladesh by collaboration between American and Bangladeshi researchers. And so this treatment for cholera, for severe cholera in rural areas, has come home, if you will, as reverse technology. How many of you have used Pedialyte for children, for pediatric disease? It's the treatment of choice for diarrheal disease in the United States. And very few people realize or appreciate that that discovery came from research done in Bangladesh, which gives you the idea that that what we learn internationally can have real impact at home. And the value of the research that was conducted in Bangladesh, probably under $20 million, is dwarfed by the amount of cost and expense in the Pedialyte industry in the United States. So this is a gift that's attributed to saving 1 million lives a year, and it all came from this global health research. And I think this is one of many examples of ways that global health can help. Well, when we got to Bangladesh, we were in a hospital that took care of 100,000 patients with diarrheal disease a year with absolutely no records. And so my wife set up surveillance of these patients, a 4% sample, to look at the etiology. And lo and behold, cholera, which was the disease I went to study, was much less important than rotavirus. And rotavirus was a brand new virus. It was not discovered when I graduated from medical school. And so I really changed my influence to look at rotavirus diarrhea and what we could do with it. Diarrheal disease, like any other main cause of death in young children, and all kids get it by the age of 5, so it's a disease which affects Americans and Bangladeshis alike. I call it a democratic virus. But working in Washington, you can't call it a democratic virus. It has to be an equal opportunity virus. But rotavirus caught my fancy, and because the disease affects all kids worldwide, it means that vaccines could be universally important. And because my own son got rotavirus when we were setting up the rotavirus lab at CDC, it meant that improvements in water sanitation would not make a difference, and we really needed a vaccine. Well, I got back to CDC. I talked to the head of CDC about coming back and working on rotavirus, and after an hour telling him of my experience, he wrote me a thank you note, welcome back to CDC, as head of the retrovirus laboratory. He didn't know the difference between a retrovirus and a rotavirus, which meant that I needed some communications. In the government, I'd like to say we're cheap and lazy. We never have enough money, and we never have enough people, so you have to do things which are really efficient. And so to be efficient and to document the importance of rotavirus at home, I had my EIS officer look at hospital discharge data for the United States over, here you see about a 10-year period. And what you see in this curve is that there are about 10 to 12% of all hospitalizations of American kids are for diarrhea, kids under 5. And you can see that these hospitalizations by month have a winter peak, and that winter peak is primarily in children from 6 or 7 months to 2 or 3 years of age. And from that peak, we linked that to laboratory data to show that that was due to rotavirus. And from there, we could develop the burden of disease, that this was clearly an important disease in the United States. And while we had very few deaths, This was 5% of all admissions to hospital. Now, I didn't give you my conflict of interest, but I'll tell you that a little bit later on this. But basically, we estimate from this hospital surveillance data that rotavirus was responsible for 60 to 70,000 hospitalizations, 500,000 doctor visits, and so it's clearly an important problem domestically as well as internationally. And globally, we constructed this sort of a document, a curve, to show where deaths from rotavirus occurs. And you can see that in India, about 100,000 deaths occur. And if we want to do something to stop rotavirus in the world, this is the place we should go. Another 150,000 deaths in Africa, and very few in the United States or Europe. So that vaccines which would be lifesavers in low-income countries would only keep children out of hospitals in the U.S. Well, I worked at NIH with Al Kapikian, who recently passed away, on the first rotavirus vaccine, Rotashield. As soon as that was licensed, I was at CDC, and we put it into the immunization schedule for all children at 2, 4, and 6 months of age. And we were really delighted that after 25 years, we had a vaccine for this most common cause of pediatric hospitalizations. At that time, I also had a chance to meet Bill Gates, who saw that map I showed you of the world and the burden of disease. And he had never heard of rotavirus before, but he saw our estimates of the global burden. And he said, how can this be? I don't know about rotavirus, and it kills so many kids. He said if a 747 crashed today in the world, everybody around the world would know about it and talk about it for years. But if a half a dozen 747s of babies with rotavirus crashed, it's a silent epidemic. So he got very interested, and the pitch I made to Bill Gates and Melinda was that rotavirus vaccines were a low-hanging fruit for child survival, that the burden of disease was huge, that vaccines principles were well established, and we had the first vaccine right there with Rotashield, that we could do these trials to continue and look at the impact in low-income countries, and that in 2 or 3 years, we would be able to document the impact of this disease, this vaccine, to prevent mortality. So he bought into this, and this was the first, and he always talks about rotavirus. Last year, rotavirus vaccines that we made and worked with were on the top of his list of 5 outstanding contributions of the foundation for the past year. Well, I got an award with Ruth Bishop, who discovered the virus, and Al Kapikian, who developed the vaccine, and me for our work with the epidemiology. You know, these kinds of awards endure for seconds, milliseconds. You can't be too proud of an award, because within 9 months of introducing that vaccine, intussusception occurred, a rare complication, the intestine telescoping on itself. It all occurred after the first dose of the vaccine here, and those about 20 cases of adverse events in 600,000 vaccinees led to the removal of this vaccine from the market. So even though this would have been a vaccine that saved children's lives around the world, in the U.S., where rotavirus is not a lethal disease and where intussusception can lead to hospitalization and surgery, this was deemed a risk too great to take. So here I was, having worked for 25 years with Al Kapikian, 15 years on rotavirus vaccines at that time, and the vaccine that we were going to push in the world was gone. Well, in the next couple of years, I lost a lot of hair in trying to understand the problem of rotavirus and explain away this adverse event. But 7 years later, 2 vaccines came to market, the Merck vaccine and GSK vaccine. They were listed as the most important publications of the year by Lancet. These were 2 publications in the New England Journal. The vaccines were slightly different, but both were highly effective in protecting children from newborn rotavirus in the first couple years of life. And so we went on to introduce these again into the U.S. immunization program almost immediately. by the Advisory Committee on Immunization Practices. Well, what was the impact? Here we introduced the vaccine in 2006, and within 2 years or 3 years, the blue line this is surveillance of 24 hospitals around the country for children hospitalized for diarrhea, and these are their lab specimens. You can see from the blue line specimens sent to the diagnostic lab, in red rotavirus positives, and you can see that within 2 years of introducing the vaccine, the rotavirus detections went down remarkably. And the number of total hospitalizations where specimens were sent went down as well, meaning that many of these were for rotavirus as well. So we really saw an immediate reduction in hospitalizations. Now, I was going to tell you my conflict of interest because my wife is the chair of pediatrics at Emory. And her success is the bottom line, how many children are admitted and stay in the hospital. And me in public health, my bottom line was how many kids I could keep out of the hospital. So that's my only conflict, commercially or otherwise. It's with my wife, but she's learned to live with this conflict. Well, around the country, we've seen the impact of the vaccine in the U.S., and the consequences have been enormous, both for the direct effects and the indirect effects that I won't talk about here. But the question then came, could rotavirus vaccines stop mortality? And here you see that when the vaccine was introduced in Mexico, within 2 years, mortality from diarrheal disease in general went down 40%. And this really gave us an idea that this vaccine could be a lifesaver. Here's the vaccine introduction, and here within 2 years, mortality has gone down. And it's continued to go down. So we now have rotavirus surveillance in 64 countries. We've gotten a tremendous network where we know that about a third or over a third of all hospitalizations for diarrheal disease is one of the most common causes of hospitalizations for children is for rotavirus. And we have global recommendations for its use. So I've gone from being a student of the history of science thinking about cholera to seeing the global program of rotavirus immunization take root. 69 countries with introductions to date, many in Africa, the green countries here, that are supported by the Global Alliance for Vaccines and Immunizations, subsidized vaccine from the global community. And here, the Gavi was just recently refinanced for $7 billion for vaccines, and many of these vaccines will go to low-income countries. But the question of going out there is in the area of vaccine finance. So I'm going from being a laboratory physician to a clinical physician to an epidemiologist, and now to a health economist to see how we're going to do this. The Gavi subsidized vaccines for low-income countries to be 15 to 30 cents a dose. But after 5 years, the countries will have to pay full free. And the vaccines from the major manufacturers will be $15 or $20 a child, far in excess of what these countries can afford to pay, places like India. So about 15 years ago, I began working in India with a small company through an NIH Indian collaboration to make a new vaccine for India with a price point of $1 a dose. And this past Monday of this week, I was in India with Prime Minister Modi, and here's Krishna Ella, the owner of the company, delivering the first vaccine that's now been licensed in India, made in India, clinical trials in India, that will be rolled out in India this year. And over the next 5 years, we hope that all Indian children will get this. India has about 100,000 deaths a year from rotavirus. So this is we still have a way to go to deal with a global problem. But I would say, and I give you this example of my own career because I never thought I would be a researcher. I never thought I'd be in global health. I never thought I'd think about working in a laboratory or working on health economics. But in fact, this has given me an opportunity to work with Bill Gates, to work with the Prime Minister of India, and to see amazing things happen. Well, the lessons I've learned from this for global health, and I would share with you, one is that I started thinking about global issues early in my career with a 4-year exposure in Bangladesh. And I think that if you get engaged in these activities early on, they can really provide dividends throughout life. The other thing is, I think if 30 years ago you told me I would have worked on diarrheal disease for 30 years, I would have laughed at you and walked out of the office or whatever. But I think the issues has changed so much over the years, and we're still not completely done with this activity. Partnerships in this have been absolutely essential, and I think some of my closest colleagues now are my international colleagues in research. And the bottom line of this for me was that working in Bangladesh, you're really taking the science where the problems are. And I think there are incredible frontiers of science in the developing world and globally, which are critically important for all of us to consider if we want to do medical research. Well, I moved to NIH. I was asked to join and lead the Fogarty Center, and I'd gone from a career that was dealing with one group of diseases where I was a mile deep and an inch wide, and I went to think about global health, an issue which is a mile wide and an inch deep. And I got on my desk when I arrived this document, the Disease Control Priority Project. It was a project that was hosted at Fogarty, led by Dean Jamieson, an economist, looking at where we could make our best investments in global health. And can the world tackle its most challenging health problems? What would be the best buys for global health? When this group, with the World Bank, WHO, Fogarty, and the POP Reference Council, began to look at the global health situation, you could see several trends that are clearly quite important. One was that in the 20th century, we've seen this tremendous aging of the global population, so that life expectancy in the U.S., which was about 40 years at the turn of the 1900s, is now approaching 80 years. So it's gone up about 2.5 years per decade. Now, what that means in practical terms is that if you listen to my lecture for 1 hour, you're going to gain 15 minutes of life. So it's a good reason to think of. But you can also see here that many countries with very low incomes have reached a life expectancy that's greater than 70 years. So that's quite remarkable and quite new. What does that mean about global health? And I just give you this one example of China, because I've been going to China for about 40 years now, and I've seen amazing changes. Life expectancy there was 40 years in 1960. It's now 74 years. So life expectancy there has gone up 5 years a decade. 5 years, imagine that. It's the most incredible prolongation of life in the largest country in the world in the history of mankind. What are the consequences? Well, clearly, when you look at the diseases of global health today, in sub-Saharan Africa, we still have HIV, AIDS, TB, malaria, diarrheal diseases, and the like, what you might expect. But in the rest of the world, cerebral vascular disease, cardiovascular disease, the number one cause of death around the world, perinatal conditions, unipolar depressive disorders, a major cause of DALYs. So the profile is quite different. And that becomes the profile that we have to think about for global health in the 21st century. These are things that we never thought about. Until the 20th century, global health was geographic medicine, tropical disease, infectious disease. The 21st century, global health are all of these diseases that we're thinking about and that we share. So the best buys that came out of that disease control priority project had to do with the non-communicable diseases. Everything from neonatal mortality to tobacco use and environmental hazards. It's clearly a different profile, and it means that people thinking about global health issues in the 21st century have to think differently. So, changing patterns of disease, dependence on new solutions, the idea that we share common problems around the world, the opportunities to think about leapfrog technologies. Our mindset has to be completely expanded from where we were. It's not just the realm of infectious diseases and pediatrics. So at that time, with Dr. Zerhouni, we convened the directors of NIH and we asked them what global health meant to them. We started with Tony Fauci, head of allergy infectious diseases, and clearly these were problems of infections, and infections know no borders, and he could look around at this map and say that we have to protect our frontiers. But then I went to the head of NCI, and he said that 85% of the cancers in the world occur in low and middle income countries. And many of these lessons about global health, we really are learning from our low and middle income country researchers. And you scratch your head, how can that be? What can we learn about cancer in the developing world? Well, I took, right after my internship, I spent time with Sir Richard Dahl, probably the most important epidemiologist of the 20th century, who worked on the relationship of smoking and health. And when I was there in the 70s, he had finished 20 years of the doctor's studies, which showed definitively the association that smoking with a half a dozen cancers, heart disease, and the like. We asked Sir Richard what was he going to do about smoking and tobacco in England, because he had made this tremendous finding. He looked back and he said, Roger, he said, I'm an epidemiologist, I'm not a politician. Those are issues for the politicians. And consequently, you can see here on the left, the trends for lung cancer mortality in the UK over the past 60 years. And it really has come down about 75, 80%, but we still have lung cancer today. There's a little twinge in the feedback. Can you still hear me? Not sure what's happening. Or I think both of the mics are on. You can see that lung cancer went down 80% over the time. It took a long time with lots of deaths. I think I'll turn off this. Can you still hear me? Yes. Okay. It's still ringing? 25 miles across the English Channel in France, with the same database, lung cancer rates went up, almost a mirror image. Is there someone in audio that can take the ring away? Okay. Let me just take that back. With the same knowledge, with the same database, there was a completely different response with the rise in cancer rates from smoking. So it really documents the fact that the knowledge isn't enough, and how do you implement the interventions to control this important risk factor. And in China, the biggest risk factor for the 21st century, one of the biggest risk factors is going to be smoking, which will affect tremendous numbers of people in the years ahead. And with the rise in the economics in China, 70% of men are smokers, women are just beginning, and the consequences of this are going to be huge. So smoking has got to be a huge problem still. In the United States, my 23-year-old son smokes a hookah, and he says, Dad, that's not a hazard. It's much better than smoking cigarettes. But in fact, the hookahs are much more hazardous, and we know about that from research that Fogarty has supported in Syria on consequences of hookah use. And e-cigarettes have become another risk factor. So clearly smoking is still with us. But another area that in the etiology of cancer, the first link of a virus to cancer came not from research in the U.S., but from Dennis Burkitt working in Uganda on Burkitt's lymphoma. African lymphoma. And that link between viruses and cancer has really led to the elimination of both hepatomas and now cervical cancer, or the control through vaccines. So we've learned a lot just from this association. Moreover, the first use of anti-cancer drugs was not in the U.S., but was with Burkitt's lymphoma. And this lymphoma melted in this child, as you see, in 2 weeks from treatment. It really gave a boost to the importance of cancer chemotherapy. So there's a lot we can learn from the global health agenda. Another example in cancer and genetics is this woman, Funmi Olopati, a Nigerian working in Chicago. When she came to Chicago and working in the inner city, she found that African American women presented with very fulminant breast cancers that didn't seem to respond to treatment. And many physicians said, well, it's a problem of access, and they don't take their medicines, and that's why they present this way. Turns out that Funmi said, this is exactly what I see in Nigeria, and the problem is not access to care or social determinants. This is a problem of genetics. These women are triple negatives for 3 receptors of cancer drugs, and they're triple negatives. African women, 70% of them are triple negatives. Caucasians, 16%, and African Americans are in between. So that our understanding of triple negatives right here in the United States has benefited from the eyesight of a Nigerian oncologist looking at the problem of cancer in our African Americans. Well, genetic examples, I went to Francis Collins, who was the head of the Genome Institute at that time, and I said, what's the importance of global health for a genome? Well, Francis said, the U.S. is a melting pot of our genes, and if you want to really understand genetics, we really have to look at foreign populations. And in fact, when he became, as head of the Genome Project, he set up the HapMap project to look at genetic diversity in Africa as one of his key activities. And now as director, he's supported an activity to look at H3 Africa, human heredity and health in Africa, to look at the differences in disease presentation and the value of genetics in looking at, and genomics in looking at disease presence. Also, you can see that from around the world, we've inherited our genes. So things like sickle cell coming from migrants from Africa are problems in the United States today. And if we want to study sickle cell and its distribution, we really can go well to Africa to learn about it. Huntington's, Chorea, neurologic disease. We never thought of this as a global health issue. But if you think about Woody Guthrie, who I remember from my college days, "This land is your land." Do you remember that song? "This land is my land." He died of Huntington's, Chorea, a devastating disease. And it turns out that the genes of Huntington's have been found, or were found by Nancy Wexler and Francis Collins in Venezuela, a community of Huntington's patients that came from a single descendant, a single woman from Europe. And that community has about 18,000 individuals who have carried the gene, and it was from this community that the genes of Huntington were discovered. Those same genes have given us insights into Alzheimer's, kidney cancers, ALS, and a number of other diseases. So it's from the Global Health Initiative that we've learned a lot. And if we have solutions to the Huntington's problem, we're going to learn that and be able to test interventions in these kinds of concentrated communities. Now, the worst problem in the United States for the next generation, perhaps for your generation, will be Alzheimer's. And 1 in 3 of you in this room, if you reach the age of 75 or so, will have Alzheimer's. So it's going to dwarf our medical care system. How can global health research help us with Alzheimer's? Well, I would show you this concentration, the study of Alzheimer's in Colombia. Again, another group in Colombia, descendants of a single woman who migrated about 1745 from Europe. You can see the descendants, and it's in this group of patients with a Paishem mutation here, that this group has a high prevalence of Alzheimer's disease with early presentation, rapid presentation. So these patients are now being followed for new biomarkers of disease and for new treatments, and some have been actually brought to the United States for testing, I think here in Denver, if I'm not mistaken. So global health has gone way beyond. Here's just to suggest here in Ghana, sickle cell anemia. In the U.S., we've dealt with this and have new treatments that have been introduced over the years through research. And so a person with sickle will live to adulthood. In Ghana, 80% die by 5 years of age. And in a disease that has a prevalence of 2% in newborns, this is as much as diarrheal or respiratory disease of newborns. It's a genetic disease that's a major cause of infant mortality. So here's something where health disparity, if you're born in a different country, your outcome is so completely different, even though we know how to treat these patients and where global health research could lead to new innovations. Furthermore, about 20% of these patients in Ghana survive to adulthood, which means they have some genetic mechanism that allows them to sustain fetal hemoglobin. So if we could learn those turn on and turn off mechanisms, we might be able to find solutions at home. And finally, environmental disasters. And I see David, I think, in the back of the audience. Environmental hazards are clearly global, as don't have to tell you about that. But what we've learned about many hazards, from asbestos to methyl mercury poisoning, have really been learned from work in global health arena, or arsenic, nuclear crises. What can we learn from the Japanese? So with that review, we said, what can we do at Fogarty that's different? How can we get out of the mold of just infectious disease and HIV to other things? And our mission at Fogarty is really to address global health challenges through innovative and collaborative programs for research and training, and capacity building is a main issue for us. And to advance the NIH mission, which to me means we help all the other institutes at NIH. Well, the 27 institutes, when I got there, only several of them had real programs in global health. I think today it's changed markedly. And our portfolio, as I got there, were basically research training programs between U.S. and foreign investigators and the development of international capacity for research. And this is really our sweet spot. So our strategic plan has been to build research capacity and to build individuals who will be the next generation of researchers, to stimulate innovation in research on global health issues, implementation science, because so much of what we've learned we're not doing. Just like that sickle cell example, because we're not applying these things, just like smoking. If we learn to apply and put research around implementation, we could go a long way to dealing with many of the world's critical problems. Moving away to include the non-communicable diseases in our portfolio and working with partnerships, because these are going to be essential for the future. Well, our first program was an AIDS international training program. Just as an example, when we started this program, 1988, AIDS was a domestic disease, and no one thought about the disasters that would occur in Africa and around the world. So we began training international scientists in AIDS-related research. From those investigators, we've ended up with a whole slew of people who trained through Fogarty programs early on. Remember, I called it early career education. Have collaborated through partnerships with U.S. institutions and other institutions, and have really become leaders in the field and independent investigators. It really reminds us that we as Americans have no monopoly on brains, and really through these extensions with foreign researchers, we can do so much more to build capacity. So this is where we have been putting our money. And the breakthroughs, almost every major breakthrough in AIDS research has occurred using or involving graduates of Fogarty programs, whether it's been circumcision and PMTCT or looking at comorbidities. So we really see these researchers as extension of the global community. Now, who have been the global health leaders in the U.S. over the past half a century? Well, here are some of them, a few, and there are three things that they share in common. First, they're old white men. Okay? Second, they're almost all in infectious diseases, except Alan Rosenfeld. But most important, they've all been steeped in an early childhood career experience in global health. They've all gone someplace, worked there for a few years, and absorbed those lessons and brought them home for their research career. So who are going to be the next generation of global health researchers? We at Fogarty last year sent out about 80 medical students and fellows to research laboratories in low and middle income countries and postdocs to have 1 year of mentored research. For postdocs and fellows, they've done their early research to apply for a K Award, to build up partnerships, to work in places like Zimbabwe, just like Tom Campbell did about 15 years ago. And many of those relationships, it's like matchmaking, it's like love. They'll stay together through thick and thin, and there's a synergy of what happens that's really enduring. So I think that's one thing that we've really tried to do. We've also extended the program with interactions with the Fulbright program at the State Department. And then we've supported through Fogarty many activities that are absolutely essential in low and middle income countries to support research, like ethics programs, because without ethics you can't do clinical research of quality in a lower middle income country. We've worked on a framework program because when we look out at where are the innovations in global health coming, it's not just the doctors and the public health people. It's the engineers and the bioengineers who are developing point-of-care diagnostics or simple imaging techniques. It's the business people who know about supply chains and distribution. It's the economists who can think about health priorities. Journalism, lawyers, and all. So we put out framework grants around the U.S. to bring university campuses together around issues of global health. And in many places, this has become a prime major for undergraduates. We've included implementation science in our strategic plan because we see that this is something that's underrepresented in the NIH portfolio. We're really good at discovery science and new innovations. We're not real good at getting ideas into practice in low and middle income countries, and we think we can make tremendous strides in that direction. And this idea has been picked up by the World Bank now and USAID, so it's really gotten a following that really we think started in some way with the stimulus that we've had at Fogarty. The tobacco program, I already mentioned how important that is. And it's an ongoing struggle to see how we're going to promote global control of tobacco. But certainly now, unlike 50 years ago, there's a consortium that includes Gates and Bloomberg and others to get this. Another area, environmental hazard, is indoor cook stoves at the high rates of people using cook stoves. And the mortality estimated now at about 4 million each year for a variety of different conditions, not only respiratory illnesses and low birth weight in kids and asthma, but cardiovascular disease, cancers, eye disorders, burns, and the like from complex exposures. So we now have a consortium of NIH, led by NIEHS, looking at particulate matter, biomonitors, personal monitors, and thinking about where we can go. We know that biofuels are terrible. Improved fuels are absolutely needed, but can only be used in some areas. And there's a global alliance for clean cook stoves that's trying to get 100 million families to have clean cook stoves over the next generation. So the challenge is, from the Global Alliance, Hillary Clinton is the lead. Can we get 100 million families using clean cook stoves by 2020? And the challenge for us at NIH is, can we achieve the impact on health that we'd like to see? So that's the challenge, and that's one of the agendas we're working on now at Fogarty and as a trans-NIH agenda. Other issues that are key, things like mobile health. because there are more people in the world today who have cell phones than have toilets. And we can clearly access people and use these as interesting diagnostics. Here's a cell phone microscope, messaging, e-learning, contacts, ambulance services, and the like. There's so many novel innovations around the mHealth space and health that we think this is a tremendous growth area. Glucometers, Fitbits, calorie counting, cardiac monitoring for arrhythmias. So this is an expansive field, and we see this as a leapfrog technology. We actually have an RFA from Fogarty. We had over 100 submissions for our first RFA. We've never had anything like that before. And finally, I wanted to just end with this medical education partnership initiative that we've conducted with PEPFAR, $130 million over 5 years. And here at Colorado, Tom has been one of the investigators on the Linked Awards in Zimbabwe, trying to build up not only medical education in African medical schools, but research, because we think that the research capabilities of these people is tremendous. And research is what keeps people retained in country. It makes leaders of clinicians. It makes leaders in policy. So this is an incredibly valuable and important program. So the MEPI partnership here, I just have Tom and Ed, the cardiologist, has been absolutely wonderful as one of the examples of ways that Colorado has been engaged in this agenda. I visited Zimbabwe. I was most impressed by the fellows who were in this program. One fellow was working on Kaposi sarcoma, had 3,000 patients with this disease in their cohort to look at treatment and understanding of the disease. Nowhere in the world can you find a cohort like that of patients with a single disease. And if you want to study this cancer, this is the place to go. Similarly, there was another fellow, young fellow, doing neurology. One of the issues was that patients who come into the hospital in Zimbabwe, 28% of patients with stroke die in the hospital in the first week. Why do they die? And this fellow looked into the cause of death and found that aspiration was the cause because they didn't have a gag reflex. And once you put the gag reflex testing in the emergency room, mortality went down to 7%. So in just a little research by a thoughtful investigator, a thoughtful young investigator, trainee, could make such a difference in the mortality outcome. Well, there are lots of areas where global health is going. The obesity epidemic, climate change, addictions, global addictions. These are problems that we all share. And it's through global health research that we're going to get some of these answers. So I've become an astrologer. Why am I an astrologer? I'm a scientist. I'm an astrologer because I work in Washington with a president who is committed to a science and global health agenda. My NIH director, Francis Collins, has put this as one of his 5 themes. We've had, since I've been there, a consortium of universities for global health. So we have over 160 U.S. universities who've come together to form a consortium to think about common issues in global health research and training and activities. And if you don't go to the meetings, they're incredible meetings, especially for students and fellows and people interested in opportunities. And there are lots of new advances. The stars are aligned. Funding for global health has gone up massively and globally over the last decade and continues to do so. The consortium of universities I mentioned, the idea of getting all parts of the university, and we have groups of engineers who come. We even have surgeons who come, including one of my favorite surgeons who's here today, my daughter Nina, who's at Denver Health in trauma. So nice to have you here, Nina. The UN General Assembly has made the non-communicable diseases a global health issue. Never did we think that this would have the attention that AIDS, TB, and malaria have received. And of course, Francis Collins' 4th mission is to expand research in diseases affecting the developing world. Why would someone like Francis Collins be interested in global health? He's a basic scientist. He's a geneticist. There's no reason to be interested in global health. Why? And he actually ended up going to Africa as a young resident and working in Nigeria as a physician. And there he saw patients with diabetes who didn't have the normal phenotype of diabetics. And so he said, there's something funny here. Let me take a look. And as a geneticist, he looked at the genes. Where else would you go if you're a geneticist? And he found the first genes of diabetes in these patients and the defined-to-do syndrome. So I think this really energized him and got him involved with H3 Africa, another NIH program with Wellcome. So what can the University of Colorado do for global health? Well, I think you're doing a lot already, and I'm impressed, Steve, with what you've done with your presentations to me this morning. Electives, rotations, but really building long-term partnerships with a few institutions where you can build capacity for research on topics that are clearly of global interest. And I think, Tom, your group in Zimbabwe has been doing just that. And things like the cardiomyopathy of newborns and pregnancy in newborns, clearly something that you can't study anywhere else. So there are lots of opportunities, and those long-term relations are gifts that keep on giving. Many opportunities like we've never had before. Another grant, and I just picked this one out, an old grant, something that links Denver and altitude with Bolivian altitude, the problems of high-altitude physiology and birth, chronic hypoxia, and the chronic problems of these exposures. So nice FERCA grant from Fogarty to Colorado. So just in closing, why invest in global health? Great science, and we think it's really a new frontier of science that needs to be expanded, both by us and by our partners overseas. Hillary Clinton called this smart power, and she really put money into this because of the idea that it was not military power, but smart power. Good for humanity. I think we all see this as a common value of mankind. Good for business and competition, and you can see that many of the diagnostic companies, vaccine and drug companies, see this as opportunities for growth. Great for our war on terrorism. If you don't have hope, health is a part of giving hope. It's good for our own future. It's just the right thing to do. So with that, I really want to thank you for the chance to talk about this, to visit and see what you're doing. Direct you to our Fogarty website because we have funding announcements and opportunities for students, for grant people looking for grant opportunities. And I want to thank you, Tom and Steve, for welcoming me here. And Bob Friedman, the head of psychiatry, was my medical school classmate. So I thought he might be crazy enough to show up, but I'm going to see him later this afternoon. Thanks so much. I'm so delighted to be here, and I'm so glad that my daughter was able to join us, Nina. Thank you. Thanks so much. Questions? Yeah.
You know, when I worked in Guinea, I was constantly amazed at how the leading diagnosis in women wasn't malaria, TB, HIV, but COPD from the cooking plant. But it's amazing how refractory that problem is a solution. You mentioned this cook stove idea.
Yeah.
It's been around for 20 years. It hasn't worked. And in fact, there was a big paper 2 years ago that drew a lot of attention and response from the Global Alliance that in India, it hasn't worked. The houses don't repair it, keep them repaired. They consistently revert to the traditional methods. No demonstrable benefits on health. Is it naive to think that these sort of simple technological solutions are going to work?
A great question, and I think that's part of the reason we got involved. This Global Alliance for Clean Cookstoves did not have a research agenda. It's just like putting 2 wells in Bangladesh. Our concern is that after, by 2020, when 100 million families have clean cookstoves, we're not going to see any measurable impact on health. How can we do that? How can we let that happen? Kirk Smith, who's been one of the key researchers funded by NIEHS to do studies, has looked into this for ages. He just came out with an editorial this past year saying that we really need clean fuels, not clean cook stoves, because the level of reduction of smoke in houses from even the cleanest cook stoves, isn't adequate to prevent some of the consequences. And so with the Cook Stove Alliance and with NIH, we're looking at a number of countries which are doing amazingly interesting things. One is Ghana, where 50% of the homes will have liquid natural gas by 2020. So they're really changing from biofuels to natural gas, and we'd love to see and document the impact of that change from old fuels to new cleaner fuels will have on health. In the short term for ARIs, low birth weight, asthma, and maybe heart attacks, but in the longer term, some biomarkers for exposure. In Ecuador, the Chinese are working with the Ecuadorians to introduce rural electrification, just like we had here in the United States in the early 20th century. That electrification probably had more impact on health than any other single intervention. So again, we would like to see and document how that program rollout will impact and improve health. So I'm in total agreement that if we just go for clean cook stoves, we're not going to make an impact. There are other issues, though. One is we need to have biomarkers for long-term exposure, because otherwise we're going to have a hard time looking at the chronic diseases. The second is that in many areas, and I took my son hiking in Tibet, we went into a yurt in a terrible cold situation, and that yurt was warm from the cook stove, but I couldn't see my son across the room because it was so smoky. And so the clean cook stoves that we're talking that are quite economical don't provide heat, and that's going to be the next challenge. Some places, like in Peru, you might have a clean cook stove in the summer, and in the winter have a heating stove. How that will impact health, we don't know. But the environments in which cook stoves will be used are so diverse, 3 billion people use it. This is a huge challenge. If we don't address the challenge, we will feel terrible that we continue to have a terrible exposure that we haven't addressed. If we address it, at least we'll be able to see the impact, and this could be the evidence for a global campaign to improve this respiratory health. Is clearly a huge problem globally. So, and I agree that in the past, by just improving the cook stoves, won't work. The Global Alliance this year at their annual meeting, for the first time, and after the Kirk Smith editorial, had people from the global liquid natural gas community, and some people in electrification, and some people with solar furnaces. First time they moved from cleaner cook stoves to cleaner fuels. And I thought that was a huge move for a bunch of people that haven't really embraced the research agenda. Yeah.
And it's also good to know there, but I was wondering if you could comment on Fogarty security. Maybe that's not really across an IA.
We really haven't engaged with the food security director. There's a lot of interest in global obesity. There's a lot of interest in the transition countries which have malnutrition and their own obesity. There's no obesity working group, but we haven't taken on that interest. We have some grants on that area, but now malnutrition is a rare disease, but we don't have a real agenda.
Excuse me, David McIntosh, Imperial College. Just a quick question. If you had limited resources, you mentioned cancer quite a bit, would you invest in lifestyle changes, cancer therapeutics, or cancer vaccines?
I think that all depends on, that's the kind of question I usually defer to NCI, because they're all Gates Foundation said very clearly, our interest in cancer is in hepatitis B vaccine, and HPV vaccine, the way to go, and making those HPV vaccines more widely available. But the others are, it's an open question. Smoking is still, after we still have smoking exhibition today. This was a struggle I had with Richard Dahl 40 years ago. When I saw him just before he died, and I said, "Do you have any regrets?" Having remembered the time when we tried to get him energized to do something, he said, "I think I should have done more early on because it's a single toxic exposure. I don't know what he would have done with that."
Roger, thanks so much. I mean, it's really great having you here, and you've been such an important part of bringing the importance of global health to the fore. I think that probably you, Jack, about getting Roger's slides to be posted on Global Center website. We usually try to post slides to people who want to access them, and that would be great. And I think the last thing is, as usual, we may have over-ordered food. So please feel free to take some of the food back to your classmates or colleagues, or we'll bring it to some appropriate house that thanks.